Well, thank you, everybody. Thanks for joining. Thanks our sponsors. I'm Rob Manske, Wichita State University and Ascension Via Christi Health. Happy to be here again for another edition of the Journal Club. And I'll introduce our main speaker in just a moment. I'll introduce our regulars, let them each tell you a little bit about themselves. Philly, start.
Bill Page, professor at FranU in Baton Rouge. Just happy to be here and happy holidays. Thanks to Ashley for doing this. Thanks to the Journal and Mike for sponsoring and Barb and everyone. Just great to be here with all you guys. Thank you so much.
Thanks, Phil. Mike, glad to have you tonight. You
Yeah,
want to
I'm
introduce
happy to
yourself?
You
be
showed
here.
up, man.
I know he
Yeah,
showed
sometimes
up.
I'm in the dark, man, monitoring the chat room. But tonight I thought last one of the year, and the fact that Phil knew it was 43, I might as well get in. But I'm happy to be here. But I'm Mike Voigt at Belmont University in Nashville, Tennessee. Obviously, it's a little warmer than Barb because I'm not bundled up like she is, or I have heat in my house, which she maybe doesn't. But
It's cold
again,
in Michigan.
as everybody can
Really cool.
understand, and we get Chad in with us here. You can see this with everybody on board that has joined us again. As I see they're rolling in, we're approaching 200 people. It's kind of low key, and you can kind of tell we have fun talking back and forth. If you got to see this is fun, we talk to each other on the phone almost every day doing these same discussions. So it's good to be on tonight and help contribute a little bit.
Thanks, Mike.
Okay.
Barbara?
Hi, everybody. I'm Barb Hoogenboom, a recently retired professor of physical therapy from Grand Valley State University. And I hail from Michigan, where it is cold, but not so cold. It's gotten warmer this week as compared to last week. I'm the editor-in-chief of IJSPT, and we're really glad you're all here to learn with us and hopefully, certainly from Dr. Lavender. But yeah, happy holidays to everybody, and thanks for hanging out for the whole year of 2025.
Yeah, no doubt. Thank you, Barb. Well, let's introduce our main speaker tonight is Dr. Chad Lavender. We were introduced to Dr. Lavender by Tim Hewitt, who's been on the Journal Club with us maybe once or twice, to be honest with you. But he works with Dr. Lavender. Dr. Lavender is from Marshall Health. He's an orthopedic surgeon specializing in knee and shoulder arthroscopy and sports medicine. And because Dr. Lavender's from Marshall, I found out he's friends with a very good friend of mine, a person that I really, really, really love, Dr. Chuck. Isn't that right, Dr. Lavender?
Yeah, he's the best to be around, I'll tell you, and taught me so much, and just a great human being. So
Yeah. Dr. Chuck is Dr. Charles Giangara. He was when I was doing my fellowship with the General in La Crosse, Wisconsin. Dr. Chuck was there, so he was one of the doctors when I did my sports fellowship years ago, and I've stayed in touch with him. And he helps me write the old Brotzman clinical orthopedic rehab text. So Dr. Chuck is helping with it now. So glad you know him, and he's just a fantastic guy. Well, so Chad, tell us just a little bit more about yourself real quick before we
Hey
start
Rob,
and
before we
jump
get
in the
started,
articles.
Rob, before we get started
Yeah,
with
yeah.
Dr. Lavender, I'm going to throw this back out because you brought it up, and you're right. You brought up a key point with Tim Hewitt being on with our guest, and it just happens. This is the same month that Tim's on because he's been on with us in December, and Dr. Lavender's got big shoes to fill because if you'll recall, when Tim comes on at Christmas time
Oh,
during the
that's
holidays,
right.
he sings songs to us
Yes,
from the he sang his favorite carols, I believe.
that's
I'll
right.
tell you, I don't see me doing any singing
Oh,
tonight, but
okay.
if we have time later, I'll tell you the story of how we met, and
All
it's
right.
related to the research and very interesting.
Perfect. Well, we'll leave the floor open if you want to sing.
Yes.
There you go.
So tell us just a little bit about you, Dr. Lavender, real quick before we hit the
You
papers.
know, I grew up in West Virginia, went to West Virginia for medical school, did my residency at Marshall, and then trained at Orthopedic Research of Virginia in Richmond, and did a specialty year there in sports medicine, focusing on shoulder and knee arthroscopy. Really, it was there that I learned to question techniques, try to develop new techniques, and they really showed me how to create surgical technique videos. And that's kind of how all this got started, was with thoughts of techniques and how to improve, our outcomes. And then we got into the research side of it. So
It's a good
Yeah.
way to do it. That's a
And
good
when
segue.
I'm not doing surgery, I coach a 10U national football team there. So that's
Oh,
kind
nice.
of that's what there is
Nice.
there.
Mike, did you see that trophy? My God, that's huge. That is huge. All right. Well, thanks, Dr. Lavender. We really appreciate you joining us tonight. And how about we get started with the first paper? I've chose the first paper. Well, both of these papers you're the lead author on, so congratulations on both of these. But I think the first one we'll talk about is the anterior cruciate ligament reconstruction augmentation with bone marrow aspirate concentrate, demineralized bone matrix, and suture tape shows no difference in the outcomes, but faster functional recovery versus non-augmented anterior cruciate ligament reconstruction. That's a mouthful, isn't it? The purpose of this study is to compare outcomes after ACL reconstruction with bone marrow aspirate concentrate, demineralized bone matrix, and suture tape augmentation versus ACL reconstruction without augmentation. So one of the big reasons that you want to see if this is if that surgery works better or not is definitely because of re-rupture rates are so high, right? And can you tell us first of all, tell us what you think is happening that's causing so many re-ruptures? And then maybe secondly, if you could kind of water it down to one or two things that you think are like the biggest things that we need to watch for that we might need to be careful about following ACL reconstruction.
Yeah, so I think historically, re-ruptures have been an issue, and we've not really made much change, irregardless of the technology and the techniques that have been out for the last 20 to 25, 30 years. The biggest issue with re-rupture actually is like any disease process. It's related to the risk. And I remember sitting at an AOS forum and a surgeon saying, if you're doing ACLs on 45-year-old skiers, you're going to be a great ACL surgeon. If you're doing 15-year-old soccer players, you're going to have headaches, right? And that's the best way to describe, in my opinion, and also in the research. It's related to the risk. So these athletes are going back to high risk environments and movement patterns that caused the original injury in the first place. That's why we have issues still, and we can talk about this further in a minute. But even though we're decreasing the injury rate on the operative knee, we're still seeing contralateral tears, and they're still 10 to 12%. Even in our recent publication that'll be coming out next month. But I think if you reduce it really to one or two major causes, I would probably say the biggest factor is sometimes patients being returned to sport before their biology is appropriately healed. And then also, neuromuscular control. Maybe it's not fully restored. Maybe they have still a weak quad, some other things like that could have used a little bit more rehab. And I think paying attention to the timing of the return to play and the patient specific factors are very important. Having a discussion, I start really at the 3-month mark, and sometimes we have the discussion before surgery. What are your goals, and when are you trying to get back to sports, and what is important to you? We live in a time where some athletes are wanting to play club and travel, while other ones stick to the what we call historical seasons. And I think all of those things play a factor, but I tone it down to the fact that athletes that are going back to high risk environments have a higher risk of re-rupture. Bottom line.
Exactly, no doubt. And all that stuff you're talking about, their return to sport and how soon that happens, it's really got to be individualistic, doesn't it? I mean, we can't just say, okay, they'll be back at 6 months or they'll be back at 9 months, because some people can get back a little quicker, others take a little bit longer. It can't be just a blanket statement, can it?
No, and really we're not. So one of our study right now that we're working on, it's a large 125 patient study, and we're looking at, and Dr. Hewitt's a part of this, and he's on the biomechanics side, so he's running the biomechanics testing at 3, 4.5, and 6 months. We're also doing MRI testing at 6 months, which I know we'll talk about in a little bit. But we're trying to find what is the sweet spot if we could give a criteria more than just the standard hop test to return to play and other RSI scores, et cetera.
Yeah, That sounds great. That's fantastic. So do you mind telling the listeners? I know there were a lot of big words in the title and in the purpose of the study. Do you mind just kind of quickly explaining to the listeners what BMAC, DBM, and the suture tape augmentation, kind of what all that
Yeah.
means and what it is?
I'll take you through a little bit of the history real quick. Okay. So about 7, 8 years ago, we started developing this technique and called the fertilized ACL. It's also called the bio ACL. But the parts that are pertinent to this, we do harvest cells from the shin bone, the proximal tibia, and that gets spun down to what's called bone marrow concentrate, which is a liquid. It has great cellular characteristics. We also harvest autograft bone as we're reaming the tunnels, and that gets mixed up with this DBM called allosync, which is almost like the glue, if you will. It has characteristics that allow it to be placed arthroscopically, and that's really what the game changer was, is that we were able to take a mixture of cells and now directly lay those cells and the bone graft into the tunnels, and they stay there in this arthroscopic fluid environment. And that's really how we were able to change the biology of what we're doing. And what that's the purpose of that is to decrease tunnel widening, decrease the need for stage revisions, and improve the biological incorporation at the graft bone interface. Okay. The other aspect of it, the suture tape, is the internal brace.
Yeah.
Many people on this call are probably much more familiar with the internal brace. Part of it because it's a low cost option that has dramatically changed the re-rupture rates in ACL reconstruction. And we were one of the first to define it and how to use it. And then also, this is the first prospective randomized trial with it included. So.
Yeah. So the suture tape, the internal brace, you're just talking like in the elbow, like they've been doing for a while in the elbow, right? Or is it different?
It's the same synthetic type of brace, suture brace, and we used it first in the ACL. I think before that it had been used in the ankle, for example, and so and many times in orthopedics we copycat other joints or techniques, and that's how we progress, right? So that's what we did with this technique is the internal, and now the internal brace is actually included on the buttons we use for the reconstruction. So things have changed. It's changed that much. So
nice. You mentioned bone tunnel widening. Does that what grafts were used with this study? Because I thought, I may be wrong, but I thought bone tunnel widening was mainly with hamstring, kind of the soft tissue.
So both of these are
grafts.
soft tissue grafts. So this technique is more so for soft tissue grafts. And if you think of it this way, it gives you the freedom to use a soft tissue graft, which generally, in many cases, people will say causes less harvest site pain, which we don't need to get into that discussion. But yeah, so for soft tissue grafts, we don't take bone blocks, for example, with our quad. So the bone grafting of the tunnels allows you to use a soft tissue graft, but incorporate that biologic incorporation.
And then you also use some allografts too, right?
Yeah. So anybody over 25 in this study, we used allografts and had really nice results with the allografts as well. In my practice, I'll generally save that for 35 to 40 years or older. Yeah.
What allograft source do you use typically?
I use a hamstring, quadrupled hamstring graft linked construct. Okay. Yeah, but you could also use quad link, which is a quad allograft. I don't think that's really a game changer one way or another.
Yeah. Do they still use Achilles allograft sometimes?
Some will use Achilles with a bone block. I mean, really, it's a dealer's choice. I think in my opinion, I think honestly, it's depending on what size you want to use, probably the most important. And it is important to point out, I do an all inside technique, which is different from some of the historical techniques where you're making a full tibial tunnel. And I use suspensory fixation, which are buttons on the femur and tibia.
Another question I had for you was that it's not, well, maybe it is fairly common, but 2-year follow-up is really pretty impressive. I feel we've talked about this before, getting people back at 2 years isn't always as easy as it sounds. So that's very impressive. Congratulations. And I just want to know what did you do to get people to come back? I mean, what was how
I'll
did you
tell
do
you
that? What was
that
your enticement?
so we started this study that just came out before COVID or around COVID. And I learned a lot from this study in the sense of a prospective randomized clinical trial takes years. And that's with being very thorough and having high volumes and all those things. Because you wait for the 2-year follow-up. And like to your point, that's not easy to get. And I'll tell you that maybe or maybe not, my staff or myself have went to local high schools to find athletes that are in the study, and I mean they're approaching the 2-year mark. We don't hear anything back. We're not seeing anything online. And then I mean there were a couple of times, especially the hop testing in this study, we had to do it at 3 months. And so, I mean, I'm calling athletic trainers, principals, gym teachers. And that's part of, there's a couple articles coming out about this, but it's part of the special nature of where I'm located. Being a small area, it doesn't take, they can't hide very far. You understand that? I remember, so the first fertilized, this is a true story. The second fertilized ACL we did. He was 8 weeks out, and against my wishes or anyone's wishes at the time, I get a call, and he's in a basketball pregame layup line dunking, and I immediately, called the athletic trainer, said, "Get him off the court, get him off the court." And that was really the first time we said, "What's going on here? Let's look closer at this, what we're doing with this internal brace and everything." So.
Good story.
But that's a lot of tenacity to look for the athletes when they're not readily available. I think that's awesome because in a small area or when the athletes are high school athletes, they kind of run their own game. I mean,
yeah. So we typically will do 2 to 3 prospective trials at a time here, and it's very important for us when we take on a project that it leads to a manuscript that gets accepted. Okay, and I think. That's important in research, no matter what type of research you're doing, is staying focused and making sure you see it through the finish line, because it's a lot of folks have great ideas for research and they put together a great plan and abstract and all these things they want to look at, but really it's the passion and your whole. And I will say this, I don't know if Dr. Hewitt's on here or if my nurse practitioner Stephanie, but it takes an entire team of people that are all committed to making sure that you get the results at the 2-year mark and even 3 months. I mean, even that early, it takes a commitment.
Yeah, it does. But I'll be honest with you, it's just from doing research with doctors. A lot of times it starts with you. And if you're the one that's kind of spearheading it and everyone knows you're really into it and you want to get it done, and everybody kind of follows, I think, suit. So kudos to you, Doc, for doing that. We get some questions. I mean, I still have some more questions I can ask. I don't know if Barb and Mike and everybody else has any or not for you, but we have some come from the audience, and we all know Bob Gray. Bob is asking a question here. Is the mixture that you use, so the BMAC and the DBM, do you put that in both tunnels or is it just one tunnel? It's in both?
Both tunnels filled to the rim.
Both tunnel filled to the rim. Good.
It's a very forgiving, and like I said, I don't have my talk here or my MRIs or CTs that I could show you, but they're online, and plenty of, if you go to arthrex.com, you'd find plenty of videos of this. But basically, you fill the tunnels completely, and in the graft, I call it a composite graft. Some people call it like a slurry, but basically it finds the voids in the cancellous bone structure. And even when you look at the CTs and MRIs, sometimes you can even make out that graft and how it's working early on. When we do MRIs, like at 4 weeks or 5 weeks, we can start to see that early making a difference.
Good. That's good. You're part of the study, or at least one portion of the study, you mentioned that sometimes you had patients that weren't able to do their functional testing due to safety reasons that were at the therapist's discretion. And so they would have got a 0 for that score. Do you remember any of the, just because probably the majority of people that are on these on this journal club are probably physical therapists. There's usually a handful of doctors that are on with us too, but most of them are physical therapists. Do you remember any of those issues where someone just wasn't able to be tested? Was it usually a strength issue? Was it, what do you remember?
Yeah, even in our study now that I'm doing, we're doing the same testing, and there's times where they're just not ready. Let me explain. We don't rush anybody into or through their rehab program. I think that's a misconception that I always try to clear up. Okay, we're not out here releasing patients at 12 weeks. Even if they get a 95% at 12 weeks on their HOP score, we're not releasing them. Okay. Yeah. So let's say that first. And then I'll tell you that, but on the other side, and the flip side of it, if they have really nice quad control at 6 weeks when I see them post-op, then I allow them to start doing straight line, non-decelerating, light jogging. And that's really what gets the quad starting to fire. It really starts to let them have more psychological readiness. And then if that patient at 10 weeks and maybe 11 weeks is ready, they start practicing the HOP test. And that's and basically what I did, again, being from a small area, I have a lot of out-of-state patients. They're not included in any of this research. But I live in a small area, so I had all the physical therapists, the different companies, and the therapist and the head and the lead therapist come in and gave them a talk. And we talked and went through the rehab and some metrics, and that's how that happened. So if that answers your question.
Yeah,
So
no,
let me give you an example though. But if a patient comes in at 8 weeks or 6 weeks and they're struggling just to get motion, that patient's not going to be ready to hop at 12 weeks, right? So, and that happens, in a percentage of the time. But what we found is that by the 12 and a half week mark, most of our patients obviously are, and even in the study I'm doing now, I'd have to look, but the last time I looked, they were at least over 70% at 12 weeks.
Yeah, that's pretty good.
Which is very similar to the previous.
And you see them is that normally a postoperative time you see them? So it's not not that the therapist couldn't make the decision, because my guess is if you work with similar therapists, they know you well enough to know now, when they're seeing the patient, they can probably tell whether you're going to let the patient do more or not, or whether you want to hold them back just a little bit. So they might not even need to see you at the 12 weeks, because the therapist probably has a pretty good idea of what your plan of care is, I'm guessing.
Yeah, and it was interesting. They had already seen so many fertilized ACLs, and then so they were blinded in this study to what technique the patients had. They didn't know. They just know they needed testing, and then they would send us faxes with the testing, the results. However, after the trial's over, we were talking about the results, and the therapist, inevitably they would say, about 90% of the time, I could tell if a patient had a fertilized ACL by week 6.
Oh, yeah.
They were like, you could just tell. And so we do think there's an anti-inflammatory component to the composite grafting of the tunnels. In addition to that, I think with orthopedics and other realms, for example, total hips or total knees, we try to fill dead space. And I think by filling the dead space here with this composite graft, I do think it is helping their outcomes because of that.
Good. Bill, you had a question. I had a question for you, but you wanted to ask something slightly different, right?
No.
Something about sample size, power, effect size.
Well, the question was that the sample size was affected by COVID, right, Doc? And so you initially had wanted 100 subjects, but I think you ended up with 89. And so there was some question on, well, what does that do to the results if you don't
Or
have
does it?
the,
Yeah. Or does it?
or
Yeah.
does it? And what I was going to try to explain was that what it really does is just affect our confidence that the results reflect the true results in the population. And so even though, I mean, a difference of 11 subjects to get the original power that you had wanted of the 80 to 90% was pretty good, in my opinion. And you actually did a post hoc at the end, which means that you analyzed power at the end and came up with anywhere from the 43 to 62%, which gives us, I kind of give that at a 50% if you lock that right in the middle. So just for the readers who don't, and the listeners who don't always look at the statistics and understand the difference of power and effect size, I just kind of like to reiterate that sometimes. And of course, the power that we look at is the ability to detect the differences between the groups, and the effect size is the magnitude of the difference between the groups, because sometimes we can have a significant result in a low effect, which really isn't clinically meaningful. And a lot of times you'll see in the literature some studies underpowered. And I just want to explain to the audience that that means that usually the sample size was too low to be able to detect differences. And many authors who have low sample sizes will use that power post hoc power analysis. There's controversy with using post hoc power analysis, which you did, which is okay because you weren't trying to support non-significant differences. Especially in the other paper that we talk about in the second one, you found significant differences, and you're just kind of saying, hey, we didn't do a priori, so we did post hoc, and it was okay. So I just want to point out to the audience that the outcome of this study was not, I don't think, seriously affected by the sample. The big thing to look at too is your p-value. That's why post hoc testing isn't really indicated for power. You can look at the size of the p-value. If it's a really low p-value, you can kind of say, yeah, that was a pretty good study in terms of determining if there actually was a difference. So I just wanted to point that out to our audience. I think you did a great study, and I appreciate the fact that you did it during COVID, because I know that was a pain to do it then.
It was, and I thank you for your comments. I think those are great comments, and there's no perfect study. And I think, and that's why, you never rest on one outcome study and change your practice. We'd never recommend that for anyone, any surgeon, any therapist, or whatever. I think if you look at this study, every single metric that I'm almost certain every single metric trended in favor of the fertilization and the fertilized technique. When you look at like the IKDC and honestly, a lot of those, or there were several, I should say, like for example, quality of life, which was statistically significant. We didn't include it in our conclusions because of what you're describing. We felt like it was a little far to reach to make some of those conclusions, that the quality of life at 2 years was different, and so we're going to report that as a conclusion, right? You see where I'm going with that? And I think the real rationale and the reasoning behind this study was, is this safe? So when you create a new technique, the first thing you need to do is show that it's as safe as the standards that are out there that have been done for 20 years. And that was one purpose of this study. And I also would say that's also a limitation to why you don't see more prospective randomized surgical technique studies, because you're taking a risk when you bring Johnny in and you say, Johnny, you may get the new gold standard, or you may get the old gold standard, and so Johnny's mom looks at you and says, you're randomizing my son's future. He's going to be the next Pele or whatever, and so I mean, those are discussions that you have to have with patients every day, and they have to trust you. And honestly, that was a reason we went away from a randomized trial this time and are going heavy with 125 of the same technique, to really hone in on what is the re-rupture rate at 2 and 5 years. What are the MRI findings of this technique? This study really gave us the basic safety metrics and return to play metrics, the hop testing, I should say, and gave us an idea that we have something special. And then you build off of that with future studies, which I'll get to with the next study as well when we talk about that. But
Great.
I just got to say, I so appreciate that because different types of research answer different types of questions, right? And if there's a problem with adverse events, then you have to acknowledge that early on. But then if there's not, then you can go forward. And I totally appreciate what you said, Dr. Lavender, about like you can't tell Johnny that he's randomized out of the group that he really wanted to be in. It's really hard. And I have to just say, go Dr. Phil on all your stats. It's all cool, baby.
Yeah,
It's all good.
Phil, I knew you'd hit a home run, Philly. I wanted to lob that one up for you. You did great, by the way. Dr. Lavender, we have another question by Christine Karen. Does the use of the BMAC and BMP alter the rehab protocol? Are there any patients that are not candidates for use of this method?
So those are two separate questions. First question is no, it does not alter the rehab. I will say because of the internal brace, I've been more free in my rehab protocol. I allow patients to almost return to function. Let me phrase this correctly. They're allowed to progress through their rehabilitation process to tolerance, with the exception of landing, hopping, jumping, and decelerating or cutting. Meaning, I allow them to go through their strength testing and doing jogging. I'm not as concerned as I used to be before the internal brace. But that's not really the biologics she mentioned. The other question was, what was the other question she asked about the
use of the BMAC and BMP? No, I'm sorry, are there any patients who are not candidates for use
yes.
of the
So
technique?
pediatric patients, I usually soak the graft. I still use the internal brace even across the physis and haven't had an issue because you already have a graft going across the physis. Now, if it's an extra physeal reconstruction, obviously we're not doing the internal brace. It's an entirely different reconstruction. But you do have to be cognizant of that 13-year-old male and that younger female with the physes. And I will say one of the things that we added in this the trial I'm currently doing is we do left hand PA x-rays and make sure they're skeletally mature or approaching that.
Yeah, good call. Good call. Next question by, I'm probably going to butcher this name, Sweatambari Cord. In patients with multiligamentous knee injuries, this is a total different question, I think, than what we're on here, Doc. So we're going off road here just a little bit. In patients with multiligamentous injuries, how do you decide your return to sport criteria? Is it different with a more serious injury?
It depends. Yeah, I mean, obviously, I will say that multi-lig injuries. So let's say if it's just an ACL, PCL, we'll start there. That's a 9-month recovery for me at least, and usually a year versus a standard ACL 6 months for me. So I do take into consideration if there's more than one ligament. And I had that walk in this week actually, and everybody thinks they're still going to get back and play at 6 months, and not every injury is the same. Not every ACL is the same.
No, it's not. You're right. You got multiple variables, don't you?
Yeah.
Yeah. Tell us about some of the studies you cite in your discussion. Describe using the MRI to assess healing. I think this is what you were earlier. You said we'd get into talking about the MRI. So some of the studies used MRI to assess healing by looking at the metabolic activity. For starters, can you tell us how that's done? I mean, what is it actually that you look at on the MRI to determine if the graft is healing or not?
So let me say I'm not a radiologist, but I know several good ones. And so for this study that we're doing, that this is why this melts into the new study we're doing. The 125 patients, we're doing MRIs at 6 months, and those MRIs, the radiologists are actually blinded to what we drilled and what specific procedure the patient had. But they know that, they see the ACL graft. So we gave them a protocol to look at, and really what they're doing to assess the maturity of the graft is called signal to noise quotient. And that's where you use a variety of known characteristics, such as the PCL signal, and then you compare it to the signal of your ACL graft.
Okay.
Again, I don't understand the technique that he's using, but he's blinded, and he gives a signal to noise quotient, and we're using that for the proximal, the mid, and the distal ends of the graft. Okay, so we get those numbers. So we're getting a treasure trove of data on all of those MRIs that are coming back. In addition to that, he maps the knee and does the tunnel diameter. So he's blinded to what I drilled. Okay.
Mm-hmm.
So so far we have 65 patients, I think, that have had MRIs. We are on the femoral side, 0.1 millimeter difference. So very negligible. And on the tibial side, 1 millimeter different. The important fact is no patient has reached 13.5 to 14 millimeters absolute on their tunnels at 6 months, which means we theoretically and most likely have been able to negate the need for staged ACL revisions if it were to be necessary by using this as a primary reconstruction.
Gotcha. When you the other question I think you knew I was going to allude to here was, so looking at the MRI and the healing via the MRI of the graft, does graft healing typically equate to their like scores on functional performance? Meaning, if you do an MRI a year, if the graft is really healed well, do people typically do good on their functional performance tests? Is there a correlation there between the two, or is it just kind of still up in the air?
I don't have an answer yet, but I'll have one in
Okay.
5 years.
There you go.
We talked. So Dr. Hewitt and his team, they're doing not just hop testing. So we're doing hop testing, Dorsey V testing, and virtual reality type testing on the patients. And so our plan is, we're doing that for obviously return to play, but we'll be able to take those characteristics in, let's say, 2 to 4 years and run analysis on those characteristics at 6 months, plus the signals, plus the tunnel, and be able to tell you whether a patient re-ruptured, and be able to see how's that patient performing at 4 to 5 years. And those are the valuable things when you set up a study. It's not always everybody. I mean, in my opinion, everybody wants to say, well, what's this graft re-rupture versus this graft re-rupture? And while that's important, I think sometimes you lose track of the overall goal here, which is what really is mattering for this patient's overall outcome, not just re-rupture, you know what I mean, but functional outcome, as you mentioned. And do those things have a correlation that we could then create maybe a scoring metric at the 6-month point, which would be our ultimate goal.
Yeah. And maybe be indicative of how they're going to perform later even. Yeah.
Yeah. If you could get a 6-month MRI and key that with the functional testing that we're doing, and be able to give yourself a metric, that they are safe, aren't safe, or in 2 years they're going to be here or there, I think that would be something very beneficial.
No doubt, for sure. Just real quick, I have one more question before we go to the second study. You mentioned that sometimes there's an increase or slightly higher incidence of stiffness following the quad tendon. I believe it was the quad tendon allograft, right? You said. What's the cause of that? That they typically become stiffer? Is it the size? Is it?
That's a great question, and I always tell residents, and when I'm teaching or talking on this, you start a research study, And then you sometimes find more, and a lot of you on here, I mean, because you're on this talk, you understand it because you have interest in research, but you find questions that you didn't even ask before the study.
Mm-hmm.
So I started to see, oh man, a 10%, 8%, 10% manipulation rate, right? And the thought across the board, and so that's consistent with Zorogenes data as well on the quad. Okay, so the thought across the board is that that's a lot of collagen to put in the knee, and it's a thicker graft. And that could be some of the cause, in addition to some of the patellofemoral pain. It's more likely all of our MUAs were in females less than 20 years old, so I knew that that was a difficult population to start with. Okay. What this led me to do is go back and reassess what we're doing from a rehab standpoint. And I changed my practice based on what I found in this study. So what we did is I bought up well, I didn't, but Marshall did, bought up about 12 to 13 old school CPMs.
Mm-hmm.
And I immediately noticed a difference. And you asked me why I wasn't drinking tonight. And one of the papers that I was revising and looking at is our MUA CPM paper. So I did 100 patients with CPMs and compared them to the previous ACLs that we had done. And we decreased that rate of stiffness from 10% to 3%.
It's pretty good.
So I think, sometimes you have to look to the past for the future. And I don't know. And so here's how we thought of that. I mentioned that our out-of-state patients were not in any of these trials, right? Well, what we found is the out-of-state patients came in and none of those patients needed MUAs. And they would come in and they do therapy 5 times a week. They were with a therapist. They were sometimes going twice a day. They were there and really working hard to get back, and then we'd let them leave at 2 weeks, right? They came in at 2 weeks with 100 degrees on average, the out-of-state patients did. Sometimes 120 degrees. And so I saw flexion and full extension. And I said, well, it's either two things here. It's the fact that they're dedicated and have no distractions, and they're going to all this physical therapy and they're really moving their knee every day, versus our in-state patients who maybe not doing as much at home, right? Or I said they just want to get out of West Virginia. But either way, they're doing better. And so we're going to try to fix the first issue.
Stick with it. Yeah. If it's not broke, don't fix it, right? Okay. You guys ready to jump to the second paper? We're 45 minutes in, and we have 15 minutes left, and we still have a whole paper. So our second paper by Dr. Lavender is opioid use following partial meniscectomy with needle arthroscopy compared to standard knee arthroscopy, results from a randomized multi-center trial. And simply stated, the purpose of this study was to evaluate opioid use following partial meniscectomy performed with needle arthroscopy compared to standard arthroscopy. So first of all, I guess, describe what you mean by needle arthroscopy, Dr. Lavender. Again, I think that's probably something that not every listener knows what it means.
Yeah, about I don't know if I have it here, but about probably 5 to 6 years ago, Arthrex just started distributing something called the nanoscope. And what it is a needle that is also a arthroscope. Okay. And it was originally intended for use in the office and as a diagnostic tool and device. We wrote a book on how to use it in the operating room and do different surgical techniques with it. One of which obviously is the partial meniscectomy technique that you see described here. But quite simply, it's a more minimally invasive, almost incisionless form of arthroscopy. And as excited as I am about the fertilized ACL, I can tell you that I'm just as or more excited about the future of needle arthroscopy. And we now have an HD needle scope, and within 4 to 6 months, we'll have a 30-degree angled needle scope, which will dramatically enhance our visualization.
So can you walk us through kind of how you schedule it? So this is like something you do it actually in the clinic, right? or you can do it in the clinic, or do you have to do it?
And especially for the trial, everything had to be the same as a standard scope.
Okay.
So
Okay.
So you had to give the same amount of narcotics available, and then see how many they took. You have to do it the same anesthesia, same medications, everything except for the actual knee procedure itself had to be the same. So.
Okay. Are people using it in their clinics though?
They are, but I think that personally, I think that's a little risky, and also
That's what I wondered. Yeah.
Yeah, I don't really want to get into that subject, but I don't personally do it in the office for a variety of reasons. If there's an issue of anesthesia or somebody vagals, I want to have somebody. Yeah. I want to have somebody smarter than me there, right? So
yeah. All right. So your primary outcome for this study was the number of pills that the patients took over the first 24 hours post-operative, correct?
Yeah, and I think that's the conclusion, that's the title, but also that they did better earlier on at 2 and 6 weeks. And so what we were able to show is exactly what we expected, that patients were taking less narcotics, but also functioning better early on subjectively. And I think we also are finishing up a cost analysis on this, showing that it's not any more expensive than a standard scope, which is important.
It is good.
So that'll be coming out hopefully in the next 6 months. But as it relates to this study, those were the main findings. And when you extrapolate that, so the question is, well, is 1.5 or 50% less narcotic? Yeah. Is 50%, 55% less narcotic use important clinically or to anybody? Yes. When you extrapolate that across the country, and the number one procedure is a knee scope that people have, it's important that means the country would be using 55% less narcotics, right?
Yeah.
So it is clinically important, even with a size that small.
Exactly. That's what I assumed. My guess was that's how you would answer that. So I appreciate that. I think really, Mike, the other question I have, you kind of answered already for this study. So what we may do, we still have some questions left from our viewers. So if you don't mind, we can jump back to maybe a couple of those. Is that cool with you, Doc?
Yeah. One last thing about the nano. I think within 6 months, we'll probably have a technique of a single portal knee technique out, and I think the next study you see will be a single portal versus a standard scope. So you go to the OR, and we do the meniscectomy through one small 3 millimeter portal.
Sweet. That sounds good. Daniel Klein has a question. With your internal brace, are you still wanting biodex and functional testing to be equivalent for return to jumping and sport progression? And then he further says, we know the internal brace is strong, as shown in the UCL literature, but obviously not totally impervious. So are you still wanting same scores that you do with the internal brace compared to others, or?
So I use hop testing and function, and then we'll also use ACL RSIs for return to play. If they have a hop test greater than 90% symmetry, and we're getting MRIs on everybody, and their MRI looks perfect, we return them to a graduated return to play. So, and that's important too. I return them at 6 months, but if they don't have to be on the field the next day, I like them to have at least a month or two to get back into their sport. And that's a larger discussion, honestly, is what does return to sport mean? Does that mean that they're going and playing one quarter, or does that mean they go back to scoring 18 points every basketball game? And those things are not really well defined in the literature. If you really read the literature, people just say return to sport. Well,
pretty vague.
I mean, my goodness, if I'm dealing with like golfers, they return at maybe 8 weeks, right? So I think it really depends. But that's a good question.
Yeah, we need better. We definitely need better.
And I will say, I would like to point out that I have had 3 to 5 myself internal brace ruptures where the ACL remained intact.
So how does that
So the
how does
brace
that say again?
so the brace tore, and so I go in for a meniscus tear, and the brace tore. The ACL remained intact, and they were able to go back to activity without needing a revision. So, and you know, I have a publication coming out probably within 3 weeks. I just did the revisions last 2 weeks ago, and it's a 2 to 6 year follow up of this technique, showing 3% re-rupture and a 10% contralateral tear. So we're getting patients back. And again, that's kind of how we started the talk tonight. You know, you get patients back more often, they're going to tear the other knee, but we're not seeing them tearing the operative knee. So that's good.
Yeah. Well, in your first study, you had none that
Yeah.
re-ruptured,
Yeah.
right? That was
Yeah.
good.
And other studies that have looked at the internal brace retrospectively are showing 2.5%. So very, very consistent across the board.
Nice. Cord again asked, do you recommend PRP for reconstruction surgeries?
So the BMC is very similar to PRP.
The
It's
PRP?
just a different cellular characteristic matrix. No, I don't. Unless it's used like this. I've never been a fan of just injecting something into the joint after you do a reconstruction. What we developed with the fertilized ACL, like I started out with and saying, is I call it directed cellular therapy. We're taking cells and we're using a scaffold to actually place those cells where we want them to be.
Good. What's the question about the durability of your graft compared to other graft sources? So I think they're referring to the first study where you do the injections of the BMAC and everything.
So
The durability.
yeah, I mean, so we're 3% is less than a BTB re-rupture rate historically. So I think you know, the durability is out there, and like I said, that's what was important about. I think that our study will be coming out within the next month, showing the 6 year follow up. Average, the mean follow up is 3 years. So we feel really good at this point about the durability and safety and really efficacy of the technique.
Nice. So last question I think we've got here from this one. We love it when people do this. They don't put their name. So it's the anonymous attendee. What are your considerations in treatment for rehab for um, like a person who had their ACL repair and then re-ruptured? So I guess they're asking about a revision ACL reconstruction. What are your considerations and how do you like their rehab to progress when you're seeing for a revision?
Simply, it depends on why they failed the first graft. It depends on what type of graft they had initially and what type of graft I used. Did they need a bone grafting stage procedure? All of those things matter. If it's a straightforward ACL traumatic injury and it was a well done ACL, and I just go in and redo the ACL, or if it's one that I did, then usually 6 to 8 months.
That's not that much horribly slower, so that's good. Good. All right, Phil, Mike, Barb, you guys got anything? Ash?
I can introduce.
Nothing for Doc?
I had a dumb question, but you said you get MRIs on all your patients. Like who pays for that? Like, especially if it's a high school student. Like, do you guys have funding in your trials for that, or how does that work?
So that's funded. Yeah. So our trials are funded.
Mhm.
And we basically worked out a cash price with our hospital system, and it comes
Oh,
out of the
awesome.
grant. It comes out of the
Awesome.
grant. So we've really been able to, I think now, if you include this study that we did originally, we probably already
Mhm.
have 100, but hopefully we'll end up with about 150 MRIs post-op.
Yeah, I figured as much, but I just wanted you to let the audience know because, like in my town, that probably wouldn't happen.
Yeah,
Yeah.
it's difficult.
Hmm.
There's like I said, there's you know, I joke with people. I'm 44 now, and I tell people I don't know if I have maybe 1 to 2 more of those prospective randomized long-term studies, so it takes so much on the front end and just organization to do a surgical randomized controlled trial. So
They take a lot out of you.
yeah, I mean, and that's why you see so much in the literature of just systematic reviews and meta-analyses and those retrospective studies. I mean, that's why, because there's a lot of thought process, and that's honestly, I don't know if Hewitt's on here, but that's the biggest help he's been is really formatting the how, why of what we do, and formatting, making sure that we're answering appropriate questions with our research, right? And I'll tell you, Rob, before I get off here, the story of how I met Dr. Hewitt.
Oh, that's right.
Really
Yeah. Thanks.
So
Thank you.
we're in Nashville, and a colleague, a mutual colleague in the industry. So he had just written his article and was talking about 2-year return to play. And I'm just releasing some of this early data from that trial we talked about, 3-month hop testing. And so they said, listen, they looked at me, the colleague said, I'm going to introduce you to someone, and you guys are just going to have it out right on Broadway at Nashville or whatever, And so we meet at a nice restaurant there at the meeting, and we immediately hit it off. And exactly the opposite of what the third party thought, because he had really good reasons and rationale for his belief. I had really good data and science behind what we were doing. And we said, look, let's work together. And that's how our relationship started. And he ended up at Marshall. And I'm very thankful to have him on board, and always able to ask him questions. And I think we've had 3 or 4 emails already today back and forth about something. So, we have a great relationship, and I'm very thankful for him.
You should ask him if that was before or after the Jimmy Buffett concert in Nashville.
That's exactly right.
Yeah.
No,
if he was wearing a Tootsie's t-shirt, I bought him that, and it was after.
And we were all at the Jimmy Buffett concert.
We were all there, and I have the proof.
Yeah, no.
All right, I'm going to introduce Rachel so we can get her.
Thanks,
on.
Doc.
I was just going to say, Dr. Lavender, there's still just another short time here if you want to get a song in, that Christmas carol.
We could do it.
All right, Ash.
So Rachel is a former ATI resident, residency graduate. She actually did her residency year during the COVID year, so she has a couple of different familiarities with Dr. Lavender here with various things. She's now part of the ATI staff and faculty for the residency program, and she has some personal experience with ACL repair pretty recently. So Rachel, I will let you take over, and if you should be able to share your screen. So if you need to do that, go for it, and we'll let you present your cases.
Sounds great. I actually might go with not sharing the screen just for science sake, because, finding out how to do that is always fun. Anyways, I'm Rachel. I've been a PT for 5 years with ATI in Greenville. And like Ashley said, I have some personal experience. I am currently 14 weeks to the day out of an ACL repair with an internal brace and a large lateral meniscus repair. So I am one of the unique ones on the ACL repair side of, I did not have a full rupture. I had a small avulsion of the anterior portion of my ACL at the tibial eminence, which has resulted in a loose body removal and the internal brace there. And so I have ended up as a patient and learned a little bit more on the side of repair. And I'd love to reiterate what Dr. Lavender says about being able to progress a little bit faster and, regain some of that quad strength faster than you would typically expect for a 14-week out ACL repair and lateral meniscus repair friend. I have a somehow 87% quad limb symmetry index and a 92% hamstring limb symmetry index. Granted, maybe my other leg is not as strong as one of our high school athletes might be as a 30-year-old female, but was definitely quite shocked when we did start getting back into some of that, heavier strengthening, how quickly I was able to regain that. Similar to what Dr. Lavender was talking about on some of the stiffness aspects, I am on the 30 plus end of the age spectrum. So I have had a little bit more challenges with stiffness, especially in flexion. we, consider the lateral meniscus repair in that as well. Currently today I was 137 flexion on my involved side and 154 on my uninvolved. So I am probably one of the, higher ends of flexion of the spectrum for a baseline that we might be looking at, but that has been a slower part for me, is regaining that flexion. Really, I would say, reiterating, even though it is an accelerated protocol, when you are having these ACL repairs done with an internal brace, we have to consider, of course, other surgeries that are occurring with it. If it's a strict ACL internal brace, we had another younger female in the clinic who had one about 5 or 6 months ago, and she was back to straight line jogging within, I would say, 8.5 weeks. So she was able to progress a little bit quicker than me, just in terms of, not having that lateral meniscus repair done. And she was also a ACL internal brace that was done as a revision from a reconstruction that then had grade 1+ laxity. So another unique case in comparison to Dr. Lavender's studies here, where it was the reconstruction plus the brace, but big considerations for, regaining neuromotor control, making sure that, strength testing is where we want it to be. I haven't quite started my hop testing yet, just from the edema that I have from being a 30-year-old PT who's gone back to work and having to manage being a patient and a physical therapist at the same time. But we're looking forward to doing a little bit of hop testing here soon and starting that progression. So maybe I'll have some more information on that for you guys in the coming weeks, but haven't quite gotten the time to do that in life. I would say the biggest thing for me has just been gaining a better appreciation as a patient and a therapist of 5+ years of, what that progression really looks like in a more accelerated protocol compared to what our standard protocol is, and how much more effectively I've been able to regain my quad strength than probably how I would if I managed to have a full tear. So I would say that's my big things.
Great. Dr. Lavender, do you have any questions for Rachel?
Well, I just think that it's really outstanding. I didn't know, Rachel, I didn't know you were going to be on here. I didn't know they were going to have a patient with an internal brace, and I'll tell you that while you were talking, like I go back to 7-8 years ago. So there's a difference in using the internal brace in the knee joint as opposed to like a UCL repair. Mm-hmm. And the issue was surgeons were scared to death of synovitis and issues and cartilage damage. And, it wasn't, when I first did the technique, and Pat Smith did a lot of research on it in canines and people as well, from the University of Missouri at the time. And we got a lot of pushback on using an internal brace. And because of the questions about synovitis, and it was just, are you going to capture the knee? Are you going to over constrain the knee? Is it going to weaken the ACL graft and ligament? All those were questions. And so the most rewarding thing for me personally, 7 years into this, and is to hear stories like yours, and going around the country and hearing from people that have had the procedure, or surgeons that are doing it and having success. And so I think that sounds outstanding.
I'm thrilled with my knee at this point. So
good.
Happy to be a patient for you.
Well, we appreciate you coming on and sharing your
Thank you, Rachel.
Yeah, we appreciate that. And Dr. Lavender, again, thank you for taking your evening and sharing your knowledge with us. It's been very interesting. I've learned a lot. Of course, we always welcome people back. If you want to come back and talk more about all these other great studies you're doing, you just let us know when they're published, and we'll get you back on here.
Thank you.
Love to have you back.
It was an honor to be on here. I really enjoyed it. And everyone, happy holidays. Have a happy new year too, okay?
Yeah.
Same to you, Dr. Lavender.
Holidays, everybody.
See you guys back in January. Have a great night.
See ya.
Thank you.
See ya.